Hey everybody, I just wanted to give you my recorded version of the study guide review for your labor exam that's going to be given on Saturday. So I plan on doing the exam at the beginning of class. We're going to be in seat this week and we'll take the exam. It's 40 questions and you have 40 minutes to complete it. And following that, we'll take a short break and then we can dive into our postpartum stuff. So in the interim, if you need any help with studying, if you need any information, please reach out to me, email me. I'd be happy to meet with you individually. And of course, we can also go over stuff in clinical on Saturday prior to the exam as well. So I'm just going to pull up a couple things here. Okay. So here is our study guide, and it may not be in chronological order of the chapters. So you see here we have fetal heart tones, category tracings, fetal macrosomia, what are the risks for, interventions during delivery, amniotomy, so when we break somebody's water, cervical readiness. So again, I'm just going to open up the book and kind of direct you exactly to where I want you to go for each one of these things. There is one math on this one. Again, it's 40 questions. It's volume over time equals rate. So that's IV calculations. Remember, volume is in milliliters, time is in hours. So if you have 30 minutes, it'd be 0.5. So let's say you have 500 milliliters to be given over 30 minutes. Need to set the rate. It'd be 500 over 0.5 instead of 30, because then it would be 30 hours. So then the answer would be incorrect. So just remember that one. That is the only math that's on this exam, which is an essay style. So let me go ahead and start here with chapter 11, which is our labor and delivery process. A couple things you're going to want to know for sure is signs of premonitory labor. So labor hasn't started yet. Backache, mom might lose a pound, half a pound to a pound, or I'm sorry, excuse me, a pound to 3.5 pounds. I was reading the kilos there. So she may have a slight weight loss, backache, lightening. That's when the baby kind of drops. If you've ever heard mom say, oh, the baby dropped, they feel really low. Contractions, but they aren't strong enough to cause cervical dilatation and effacement. So they're the warm-up contractions, the Braxton Hicks. She may lose her mucus plug or have increased vaginal discharge. Sometimes an energy burst where they call it nesting. She might clean the house all of a sudden. And then maybe, some nausea, vomiting, indigestion. So those are premonitory signs. And then, of course, we have the actual stages of labor. True labor is indicated by cervical change. So if mom isn't changing her cervix, then she's not truly in labor. So the first stage is umbrellaed and divided up into 3 phases: latent, active, and transition. Make sure you know the difference between all of those. Latent is 0 to 3 centimeters, mild contractions. That may be irregular. Active, 4 to 7 centimeters. Contractions are becoming stronger and more regular. And then, of course, transition, 8 to 10 centimeters. You have very strong contractions. Again, in the beginning, mom's going to be talkative, excited, elated. In the latent phase, active, she may start feeling some pain, anxiety, restlessness, and transition, tired, irritable, feeling out of control. She may have some nausea, vomiting as she transitions. She'll feel like she has to have a bowel movement, which that's just the baby coming down. Second stage is delivery of the baby. So we're pushing at this point. Mom's fully dilated. Second stage ends when that baby is out. So that's the big show. Third stage is the placenta. It should come out on its own spontaneously within 30 minutes. If it does not, it would be considered retained. And then, of course, the fourth stage is your recovery. ATI, refers to that as 1 to 4 hours. So it's when the vital signs kind of stabilize and lochia is under control, scant to moderate rubra. Okay. Other things with labor you need to know. Rupture of membranes. We know that with rupture of membranes, the longer mom's ruptured, the more risk of infection that she has. So I don't know the exact onset of rupture of membranes. And then, of course, when we get to complications of labor, when she ruptures, we also have that risk of cord prolapse, which we'll talk about. Assessment of amniotic fluid. what it should look like. It should be clear, pale to straw colored, yellow in color. It should not have a foul odor. And nitrazine paper will confirm that it's amniotic fluid. The amniotic fluid will be alkaline, not acidic. Okay, so the nitrazine paper will turn blue and the pH will be high. So it was 6.5 to 7.5. And also remember that not nitrazine paper, amniotic fluid can fern. So if you put it on a little slide and look under it under a microscope, it will actually look like a fern plant. It's kind of cool if you ever get the chance to see it. Then we get into the 5 Ps. You're going to want to know these. Of course, your passenger. So presentation, fetal lie can be transverse or parallel. So that's is the baby laying sideways or up and down. Up and down can be feet first or head first, whatever. But that's just longitudinal or transverse. Okay. Obviously, we want the baby longitudinal and head down, hopefully. The most favorable positions, fetal positions for labor are right here. Right occiput anterior, okay, or left occiput anterior. That means the baby is facing mom's spine, okay? So LOA or ROA, those are the 2 most favorable positions for labor. Anything other than that can prolong labor and cause dystocia. Now, they can still deliver posterior, so if they're occiput, which means the head, right? Right or left occiput posterior, the baby's facing mom's front, so the larger part of the head has to deliver. So labor can be prolonged. Mom gets a lot of back labor, and the pushing, second stage could be a lot longer and prolonged. Okay. Anything other than that is going to be very difficult to deliver vaginally. If they're breech, transverse, have a face presentation or a shoulder presentation. Okay. Fetal attitude, that's their flexion and extension. So attitude, think of a kid with an attitude. Their arms are crossed, right? Have an attitude. We want that baby in a nice little ball. Okay, we want that flexion. We want that chin down, arms and legs flexed. Because if you have one extremity out, like an extension, obviously that's not going to make for a favorable birth. Okay, so LOA, ROA, okay, those are your most favorable. And we want attitude. We want fetal flexion. Okay, lie, we want longitudinal. And then of course station, that is, like it mentions here, an imaginary line. 0 station is right at the ischial spines. So negative, in this case, the baby's high. Negative in a labor sense is bad, right? We want that baby to come down. So 0 would be right in line with those ischial spines. So -2, -1, 0. Then we get into the pluses, +1, +2. Usually by +2, that head's right there. +3, we're crowning, okay? So that's our stations. Of course, the passageway, that's your bony pelvis, cervix, pelvic floor, vagina, and vaginal opening. Okay, so it all has to be adequate for that baby to pass. The cervix has to dilate and face. Of course, then we have our contractions, the powers, which we'll talk about in a little bit. Okay, and position. The most favorable position for mom to deliver would be, think gravity, like a squatting position, upright, sitting, kneeling. But a lot of times, oftentimes, if she has an epidural, she's not going to be able to do that, so she'll be in the lithotomy position. Of course, we got the psychosocial response too, or psychological response. Mom can get a lot of stress, tension, anxiety. All right, we practiced Leopold and Sim 1. Remember feeling the position of the baby. Of course, we talked about fetal monitoring as well. We're going to monitor fetuses through, labor. And the frequency of that is going to depend on mom's risk factors and how far along she is in labor. The earlier into her labor, if she doesn't have any risk factors, you can monitor intermittently. Of course, in that second stage, you're going to want to monitor every 5 to 15 minutes, but if she's got risk factors, it's going to be continuous monitoring. Pitocin induction, you're going to want to always do continuous monitoring as well. Laboratory analysis, if she's group B strep positive, remember we do those cultures at 35 to 37 weeks gestation, and if she's positive or unknown, we're going to treat with penicillin throughout her labor to prevent that from getting to the baby, okay? We're going to want urinalysis, baseline blood levels, CBC, we want her blood type and RH factor, of course. Oops, sorry about that. Trying to make you dizzy there. Okay, we're going to monitor mom's vital signs, of course, her fetal heart rate, and of course, contractions. So remember, how do we measure contractions? Beginning to beginning. Beginning of one to the beginning of the second one, and I'll show you that here in just a second. We're looking at the frequency, that's how often they're coming. the duration, how long one contraction itself lasts, and the intensity. External fetal monitoring, remember, we cannot measure intensity. We can only measure intensity by palpation of the fundus. Mild, remember, mild, moderate, strong, right? Internal fetal monitoring, we can measure intensity, okay? And of course, the resting tone, that's the time between contractions where the uterus gets to rest. We do not want contractions coming more frequently than every 2 minutes. We don't want them coming every minute, because then that uterus doesn't get a chance to rest. We could risk two things: one, fetal distress, and one, uterine rupture. We do not want to do that, okay? So that IUPC can measure those contraction strengths. All right, we're also going to do vaginal examinations. We know they dilate from 0 to 10 and efface from 0 to 100%. These are the mechanisms of delivery if the baby's in the vertex position. That's not on my study guide, so you can read through that. Let's see. On your own, do the questions at the end. Do my labor jeopardy. For pain management, I do need you to know what you can give, what's appropriate to give and not give in each stage, okay? So this table right here, please know that. So in the first stage of labor, latent, maybe early active labor, you can give opioid analgesics. Not appropriate as we get closer to delivery, because opioids, what's your biggest risk factor with opioids, even with adults? Respiratory depression. So if we give it too close to delivery, we could risk a baby coming out respiratory depressed. If given early on in labor, it's fine because it'll wear off, you know, when that half-life wears off, baby will be fine by delivery, but we do not want to give it too close to delivery, okay? Epidurals are appropriate in the first stage. Nitrous oxide is appropriate as well. In the second stage, when mom's pushing and after she's had a delivery, if she had no epidural or anything like that, if she does tear or have an episiotomy and she needs repair, she does need a local anesthetic, such as lidocaine or something like that. Pudendal block is also something that you could give. It's almost like a regional block. With that, know your risk factors. With a pudendal block, you do risk hematoma, okay? Because you're putting a big needle into that pudendal nerve, and there is a risk for hematoma with that. Lidocaine, really no risk factors. Nitrous oxide, not really any risk factors. Epidural, the main risk factor is maternal hypotension. You have to watch out for that, because maternal hypotension can cause the baby to not look so hot on the monitor. Opioids, again, biggest risk factor is respiratory depression, so they can be given early on, not later. C-sections, two options. We got, well, three. They can do an epidural block. They can do a spinal anesthetic. And then, of course, if it's an emergent section or spinals or epidurals are contraindicated, it would be a general anesthesia. So do know that table for me, please. Okay. Also non-pharmacologic. It just depends on what mom and dad want. So cognitive strategies, you know, hypnosis, biofeedback. Of course, there's sensory stimulation, aromatherapy, breathing techniques, imagery, cutaneous stimulation. Effleurage is like, if you've never heard of this term before, it's like rubbing the abdomen and a gentle circular stroking of the client's abdomen with fingertips. Sacral counterpressure, this works really, really well. Remember I said with those posterior babies where they're facing, I call them sunny side up, they come out facing up. Sacral counterpressure, put pressure on that lower back and just press. Moms with posterior babies get a lot of back pain, so that sacral counterpressure helps big time, okay? Of course, they can do hydrotherapy, acupressure. There's all kinds of things that they can do for their pain. Then we get into the pharmacological, like we just talked about. My main thing is no opioids close to birth. Know the risk factors for all of these. Epidurals and spinals, maternal hypotension, which can cause the baby to not look so great on the monitor. It can cause decels, late decels, fetal bradycardia. So one way to help prevent that from happening is, I know anesthesia, before we're allowed to give epidurals and spinals, they will require at least 1 liter of like LR bolus into mom to help counteract that maternal hypertension. If she does develop hypotension after the epidural or spinal is placed, anesthesia will give them like a vasopressor to help bring that blood pressure up. We want to give mom oxygen, of course, lay her on her left side. but we're going to be watching and monitoring those vital signs very, very closely, as well as that baby on the monitor. Okay. Here it talks about the pudendal block. Remember, adverse effects, broad ligament hematoma we need to look out for. All right. Yep. See, and here's my bolus of IV fluids. Maternal hypertension, fetal bradycardia, and then afterwards, she's going to have she's going to have the inability to feel the urge to void. So a lot of times moms with epidurals will get Foley catheters throughout their labor. Just know that after those catheters come out, that urinary retention can still be lingering, as well as with the spinal. So they may have some urinary retention that we really got to watch out for after the birth of the baby, after their catheter comes out. Okay, because she's not going to have the urge. So those are my main key points with that. Fetal assessment, we talked about Leopold and practiced that. Here are your guidelines here for auscultation or continuous electronic fetal monitoring. Please do know that, okay? Like I said, the closer to delivery you get, the more often you're going to be monitoring that baby. If they have risk factors, it's going to be continuous. No risk factors, there you go. Okay. Let's see. So remember the fetal monitoring, we have external and internal. Internal, mom has to be ruptured, if you remember that, because we're putting the scalp electrode on that baby's scalp, and we're putting the intrauterine pressure catheter, IUPC, into the uterus. Remember, internal, you can measure contraction strength, external, you can't, okay? But the internal one is invasive, and we do not want to use that on somebody who we don't want to be ruptured. Do know the categories here for the 3-tier system. Category 1 is good. Category 2 is we're going to watch it. And then, of course, Category 3 is not good. So these are some of the things that we're going to see in Category 3. A sinusoidal pattern, that means that baby is hypoxic, anemic, something's really, it's a very ominous pattern that I didn't show you and I won't test you on, but that's just a really bad pattern. If we have recurrent variable or recurrent late decelerations or fetal bradycardia and absent variability as well, would be a Category 3. Yeah, here, absent baseline, absent variability. So remember that flat line, right? Flat line, not good. We want moderate variability, which is 5 to 25 beats surrounding the baseline, which we know is 110 to 160. Okay, minimal is okay. That falls into a Category 2. It could be mom just got an opioid, for her pain. That's going to put a baby to sleep. Babies also have sleep patterns. So here's some of the Category 2. Category 2 we're going to watch. Category 1 is good. Remember, 110 to 160, moderate variability. We want accels. Accels are good. Remember, 15 beats above the baseline for 15 seconds. Early decelerations are okay because that means head compression. So a lot of times when you see early decelerations, that means that baby's coming pretty soon. So do know what's Category 1, 2, and 3. Okay. Then we're going to get into the patterns. So we know accels are good. Remember your field chop. Bradycardia is less than 110 for 10 minutes or more. Know some of these things that can cause fetal bradycardia. Okay, we don't want fetal bradycardia. Fetal tachycardia, maternal infection is probably one of the biggest culprits. If the mom's been ruptured for a long time, check mom's temp. Chorioamnionitis is the term, so above 160. Of course, other things can cause that too, like cocaine use, fetal anemia, things like that. All right. And remember, veal chop. Early means head compression. Late is placental. Loss of variability. Remember, we want moderate. We don't want absent. Minimal is iffy. We're going to keep an eye on it. And then, of course, variable means head. Variable means cord. I was looking at this. I'm sorry. Early, they mirror the contraction. That's head compression. So you're going to need to know these basic patterns and basic variability, okay? You're also going to know how to count contractions. Remember, each one of these big lines is 1 minute. So if I'm counting, it'd be 1, 10, 20, 30. So about, sorry, that's my grandma. So that'd be about 90 seconds, okay, in between each one. Frequency is, so that's the frequency. Sorry, my grandma completely distracted me. She called me twice in a row. So that's frequency. Duration is how long each contraction lasts. So each, remember, big line is 1 minute, but you can also count these boxes 10, 20, 30, 40, 50. So that one's 50 seconds long. Okay, so beginning to beginning for frequency, duration is how long does each one last. These are earlies, mirror the contraction, head compression. Uh-oh. Not sure just what happened there. Hang on. I got all kinds of things happening to me right now. Well, I'm not sure what is going on. I was on a roll. Thanks, Grandma. I'll just pull up a new page because I'm not sure what's going on with that one. Let me pull up my ATI book here. Sorry about that. Okie dokie. Back in business. Back to fetal monitoring. Let's see what chapter. Sorry about this, not trying to make you dizzy. Didn't know I could turn off like that. Pain management. Jeez. Early SAD mirrors a contraction. Late, after the contraction, okay? It starts at the peak and doesn't recover until after the contraction's over. These are the worst. Remember, these are placental. And you can see this variability is absent. You see that flat line? We got some decent variability here, okay? Variables look like a V or a W, so you'll see like a sharp, V looking or a W looking thing. I don't have one on here, but refer back to your Sim 1 pre-work. I have all of those on that worksheet that we did in class. And remember, that means cord. And accels are good, 15 and 15, above the baseline. Okay. Oh, there's variables. It's on here. Very nice. And then here's minimal variability. Okay. So, and then, yeah, again, like I said, refer back to your, you'll need to, I'll have some strips like this on the exam. Okay. Remember, a prolapse cord will have a prolonged decel where it's you're plucking along and then you'll kind of bottom out. So we'll talk about prolapse cord in a minute. I have one of those on the worksheet from Sim 1 pre-work as well. All right, so this is stages during nursing care during stages of labor. Assessing. Again, we talked about that already. Talked about amniotic fluid, how often to assess. Do you know these terms here? Lacerations, perineal lacerations. This is a recovery, recovery stage. You're obviously going to be looking at that. First degree, it doesn't really involve the muscles. Second, it extends to the skin and muscles of the perineum, but not the anal sphincter. Third, external anal sphincter. And fourth, it goes through the anterior rectal wall. So basically all the way through. So third and fourth are pretty bad. And definitely need a lot of repair. So fourth goes all the way through the rectal wall. You don't see those too often, but they do happen, unfortunately. Okay. And there's again monitoring. Again, how often to monitor mom's vitals, fetal heart rate monitoring. Really nothing too much in here. We're going to do a lot of, vital signs, bundle checks, checking their lochia. We'll learn more about that in postpartum as well. but just know that we're going to be doing, it's almost like a surgical recovery, you know, doing vital signs every 15 minutes and checking the fundus with each recovery check, checking the lochia. That's our biggest risk of bleeding is right after delivery. Remember, oxytocin will help to firm up that uterus. Everybody's calling me. Goodness. Oxytocin will help contract that uterus to help control that bleeding after birth. So she may be getting oxytocin in little increments during labor, but after that placenta's out, you can actually bolus oxytocin because that's really going to contract that uterus down and help prevent that mom from bleeding. There's other medications that we can give as well. We'll talk more about those when we get to postpartum. And remember, bladder distension, we want to encourage voiding because if that bladder is full, that uterus can't clamp down like it needs to, so that could also lead to bleeding as well. So frequent vital signs, make sure she's voiding, bundle massage, and then oxytocin to help. That's usually the first drug of choice after birth, okay? I know Bishop scores on your study guide. That's what we're looking for. It's just basically cervical ripening, so making sure that the cervix is ready for labor. If it's not and we still have to induce, there are certain things that we can do to help ripen the cervix, and what we mean is just soften it, maybe efface it and dilate it a little bit. We can give some, you know, Cervidil. I know some of you have seen some of that. There's a balloon that we can insert to help open up that cervix a little bit. So that Bishop score, we want to be favorable for labor, okay? If we still have to medically induce the mom, but we don't have a cervix that's ready, there are, like I said, a balloon or Cervidil, certain prostaglandins, things that we can do. So just be familiar with what a Bishop score is. It's favorable cervix for labor. We're looking at dilatation, effacement. Is it soft? And then the position. So is it low down or is it really high up? Okay. So here's how we can do cervical ripening. Like we talked about the balloon, they can strip membranes, a low dose infusion of oxytocin, and also some prostaglandins. Let's see. Induction of labor, that's giving oxytocin to help the uterus to contract. There are indications for induction if the mom's post-term, if her labor is kind of prolonged and not really progressing. If she ruptured and she's not really contracting yet, we want to have those, we don't want those membranes to be ruptured very long. If there's any complications, of course, fetal demise, or if she has an infection, we want to get that baby out. So elective inductions, they really won't do unless mom is over 39 weeks gestation. Risk factors for both augmentation and induction. We could cause uterine hyperstimulation. We could cause fetal distress. Amniotomy, that's where we rupture membranes. Risk of that. Once we do that, we risk infection. Watch when they do an amniotomy, make sure we're watching for cord prolapse, which again, I'll show you again. Be familiar with what an amnio infusion is. Basically, you can use that IUPC, which is that catheter that goes into the uterus to monitor, contraction strength and measure contractions. You can also use an IUPC to do an amnio infusion. Basically, you take warm saline and you can instill it right into the uterus. It can do two things. I've seen it done for different things. One, if the baby's having a lot of variable decelerations, that cord's really getting compressed, instilling that saline into the uterus can help cushion that cord and help decrease those variable decels. I've also seen it for meconium stained fluid that's really thick. Meconium stained fluid will look like a greenish color. Basically, the baby has a bowel movement inside mom's uterus before it's born. So an amnio infusion can help thin that fluid so it's not super thick meconium. So be familiar with what that is. We really need to watch what we're infusing and what's coming out, because if we think of a balloon, if we put too much in there and it's not coming out, for some reason the baby's blocking it from coming out, we could rupture the uterus and we have a huge emergency. Vacuum assisted delivery and forceps assisted delivery, they are called operative birth. So even though it's a vaginal delivery, it's called an operative birth. So obviously, baby has to be in the vertex position. There are risks associated with it. I mean, you could, cause hematomas on the baby's heads, lacerations, but sometimes we'll do that if mom's not pushing effectively or if the baby's in distress, we need to get them out quickly. Both of these would be contraindicated in a mom who has a contagious bloodborne disease like HIV, because we wouldn't want to risk, lacerating the baby and then we have an exposure. So any bloodborne disease, communicable disease like that, we would not want to do that. Let's see here. Stops. We talked about episiotomy already. Remember, if mom is not numb from an epidural, make sure that she gets some lidocaine before they repair her. That'd be like giving you stitches without repairing, or giving you stitches without numbing you. Ow. Cesarean birth. What I want you to know, why would we do cesarean births? What are the indications for it? Obviously, malpresentation, if mom's pelvis isn't big enough to fit the baby. If it's a repeat C-section. If she has a previous vertical incision on her uterus, we do not want her to labor because that can rupture. Then we have a uterine rupture. If she's got a high-risk pregnancy like positive HIV, really severe preeclampsia, active genital herpes is another reason you would want to do a C-section. Okay, cord prolapse, which is an emergency. Do know the pre-procedure actions. Obviously, we're going to want to get a 20-minute non-stress test on the baby, as long as it's not an emergency C-section. If she comes in for a planned section, we're going to want to prep, so shave her abdomen with an electric razor, large bore IV catheter, so 18 gauge. We're going to want to give her that bolus, at least a liter bolus of LR, because she's going to get a spinal epidural. We're going to place a Foley catheter, have her sign consents. All right, figure out the last time she had anything to eat or drink. All of that good stuff. Of course, educate. Complications, of course, you're familiar with surgeries just from your med-surg courses, so maternal complications obviously are going to be a lot of the same that you would see. Inter-procedure, of course, positioning. How do we position a mom in the OR? Remember, we never want to lay a pregnant mom flat on her back. That baby could press the vena cava, so put a wedge under her hip to help displace that uterus off of that vena cava. Okay, they're going to do sponge counts. Of course, continue to monitor mom's vital signs. And then post-procedure, she's going to go into recovery. So we're going to do fundal checks, check her dressing, and kind of the same things as a vaginal delivery, except just a little variant with the, the surgical site, of course. Okay. Talked about VBACs. Mom can VBAC. It depends on why she had a cesarean the first time. Again, vertical incision is contraindicated for a VBAC. If she had CPD or cephalopelvic disproportion the first time, or her pelvis is too small for a baby to fit through, obviously a VBAC is not going to be successful a second time. But if her first baby was breech, and that's why they did a cesarean, this one's head down in the LOA or ROA position, there's no reason, and she had a vertical incision or a horizontal incision the last time, there's no reason we can't attempt a VBAC. So it's all up to the mom. They always give them the option, though, if they want to do a repeat or not. All right, now we're getting into complications. Here's our prolapse cord. Remember, when the water breaks, before the water breaks, we're floating along, doing okay. Water breaks, that cord has a potential of slipping through. Baby's head compresses that cord. You have a nice, long, prolonged decel. Immediately that baby bradycardias, okay? So watch that monitor when they do an amniotomy. If you see that, what are your actions? Well, think of the cord like a hose. Get that baby off that hose. That's that baby's lifeline, okay? So sterile glove as quick as you can and get that presenting part off of that cord and call for help. Gravity helps, so put mom in Trendelenburg, or if she's able, if she's not numb from an epidural, get her on her hands and knees and have her put her chest down, because think gravity. You want that baby going this way and not this way, okay? So that's going to help get that gravity off that cord, get that baby off that cord. So you, as a primary nurse, are not going to move your hand off of that presenting part until you get to the OR and they start cutting, okay? So what you're going to see is just that sudden drop in bradycardia, okay? Call for assistance immediately. And then how do you get more oxygen to the baby? Give it to the mom. And I'm not talking a little 2-liter of nasal cannula. 10 that's, I think ATI says 10 to 12. I always just would crank it up to 15. Oh, they say 8 to 10. I would put on non-rebreather around at 15, but ATI says 8 to 10 liters via face mask. If you don't have IV access, you better get it immediately because you're prepping her for a C-section, okay? Fluid bolus. And for fetal distress in any regards, there are 4 things that you can do. Number 1, obviously, stay with your patient. You always call for help. So you want to give oxygen to the mom, okay? Reposition. For a cord prolapse, you want to position knee, chest, or Trendelenburg. But if we're having late decels, left lateral is always the best. If she's in her left lateral, switch it to her right lateral, okay? So position change, oxygen, fluid bolus, okay? And if she is on oxytocin or an inductive agent, shut it off, okay? Those are the 4 things that you need to do immediately. Of course, stay with your patient and call for help also. Remember those 4 things, okay? If the cord is protruding, cover it with a sterile saline gauze, or you won't be because you'll be holding the presenting part, but somebody else will need to, and you're going right to the OR. Okay? So that's what a prolapse cord looks like. So push that baby off that cord. Here, risk factors, know your risk factors. If you have a nice big baby and their head's nicely engaged down, they break water, that cord's not going to slip through. But what if you have a little bitty guy in here and water breaks? All the more room for that cord to slip through. If they have a lot of amniotic fluid in there, if the baby's really small, if you have an unusually long umbilical cord, also multifetal pregnancy, if you have multiples, one baby might come out and then whoop, that leaves room for the cord to slip out before the other one. Okay, so know those risk factors. Meconium stained fluid, we talked about an amnio infusion that we can do. Okay. We'll talk more about that with infants too, but it does cause risk for the infants. They could potentially aspirate it. Fetal distress, again. What did we say? Monitor, monitor, monitor. Left lying, oxygen, discontinue oxytocin, increase IV. And then if we don't get a result with our fetal distress, so let's say we have absent variability with late decels, then we're going to prep for an emergency C-section. Stocia, this is dysfunctional labor for whatever reason. It could be malpresentation of the baby, fetal macrosomia, which is a really big baby, advanced age, uterine abnormalities, okay? For some reason, labor is stalling, okay? Also, a hypotonic uterus, it's not really contracting. You can have a hypertonic uterus. Like I said, we don't want contractions coming every minute apart because then that uterus doesn't rest in between. And when that uterus doesn't rest, we risk uterine rupture and or fetal distress, okay? So we do not want either or. If mom does get hypertonic contractions, shut that Pitocin off and let her uterus rest, okay? We do not want to risk fetal distress or uterine rupture. Okay. Precipitous labor, that's where labor goes from beginning to end in 3 hours or less. So if you're the student in the room and the mom calls out and she says, oh my gosh, my baby's coming right now, stay with your patient. Do not leave. Okay. Turn her on her side, have her pant. Okay. You can give her oxygen. And precipitous labors, they risk tearing, really, like those 4th degree tears because that baby's coming out so fast and you don't have time for stretching to occur. So make sure that you support the perineal area gently and, beneath, kind of in between the vagina and the rectal area. Just kind of support that area and just kind of gently guide that head out. You're not going to be able to stop labor, or that baby from coming out. So don't hold the baby in, have her pant, lay her on her side, okay, and call for help and then support. Here's our uterine rupture, like I said, and it could be from uterine abnormalities. It could be from an accident, overdistension of the uterus. If you have a really big baby, polyhydramnios, or if you're doing an amnio infusion too fast, hyperstimulation can cause it. And then, of course, a previous vertical incision. If you're doing a VBAC, that is a huge risk factor there. Okay. Client will feel a ripping or tearing sensation. So think of it ripping open. And it's very painful, abdominal pain, uterine tenderness, and then the abdomen just looks lopsided because all of a sudden the fetal contents are just expelled into the abdomen. You don't have that nice round ball. You're just out there, okay? This is an emergency for mom and baby. Prep her for a C-section. And I'm talking like hemorrhage too. So all those things we do for hemorrhage with bleeding, like we talked about in exam 1, 2 large bore IV catheters, type and cross. For blood, of course, oxygen, IV fluids, get her ready for a C-section, okay? And this one's very rare, but it does happen, amniotic fluid embolism. So think of an embolism going to somebody's lungs. Think of a pulmonary embolism. What's the patient gonna look like? Respiratory distress. This typically happens at cord clamp or right after the delivery, after baby's out. So it doesn't typically affect baby because it usually happens right after birth. It can happen if it does emergent C-section, but if it happens after delivery, it's going to affect the mom. So basically, she goes into respiratory distress, cardiac arrest. Okay, so you're going to be doing CPR measures at that point. So you'll have sudden chest pain, shortness of breath, cyanosis, or she may just full on code. I've been there before where it was right in a C-section, cord clamp. Mom was doing great, and then all of a sudden she was unconscious, was frothing at the mouth, and they did full on CPR, and she did survive it. A lot of times they don't. So I was very happy that she did. Yeah, so cardiopulmonary resuscitation pretty much. Great stuff. And that's pretty much it. Now let's go to your study guide. I think I covered everything. Categorization. Okay, so fetal macrosomia. One thing that I do want to mention, there are two things, and I don't know if they're in your book or not, if I skipped over them, but do remember these. If you have a very large baby, and a lot of times it's due to moms being a gestational diabetic, that baby can grow really, really big, or even post-dates. Shoulder dystocia is a huge risk factor, okay, for diabetic moms and large babies, macrosomic babies. So there are two things that you need to keep in mind if you are anticipating shoulder dystocia. There are little stools in every labor room for a reason. If you have a shoulder dystocia, you need to get that stool out and do 90-degree pressure in the suprapubic area of the mother. This is kind of where the bladder is. So basically what happens is the head comes out and then the shoulders are too big to deliver. So this is an absolute emergency for that baby because that baby is going to be asphyxiated rapidly. So how do we get that baby out? Suprapubic pressure. And I'm talking 90 degrees, get on that stool and push straight down, not bundle pressure, down where those shoulders would be. So picture if the head's out, where are the shoulders? Right there. 90-degree pressure will pop those shoulders out. So that's one thing, okay? Suprapubic pressure. The second thing is McRoberts position. Pull mom's thighs all the way back to her chest. Open up that pelvis, okay? And then in addition, oxygen to the mom. The provider is going to be doing, measures. They may have to cut a big old episiotomy, whatever we can do at that point to get that baby out. Shoulder dystocias are an emergency. Okay, so remember those two things. We talked about water breaking. Remember, watch that monitor. What does amniotic fluid look like? Cervical readiness, your Bishop score. We talked about C-section. Why? How do we position and interventions prior? Why do we give Pitocin? We know why we give it during labor and after labor. We know our nursing interventions prolapse cord, what happens in each stage of labor. Remember fetal positioning and presentation. Stations, -4 to +4, the baby's coming out. Talked about pain medication, when to administer. Remember that table. Pain medications after birth. If she doesn't have an epidural, what did I say? Lidocaine, pudendal block, and know the risk factors for each one of those. True versus false labor. Cervical dilatation and face, cervical change, right? Epidural, risk to mom. Maternal hypotension. Remember what I said we did. If you don't, go back and listen. Sacral counterpressure, who do we give that to? If you don't remember, go back and listen. We know what amniotic fluid looks like. It's alkaline. It's going to turn the paper blue. Pain control prior to epidural. So remember early in labor, what can we do? Nitrous, opioids, and some of those non-pharmacological methods as well. Here's your veal chop. Okay. Also remember variability, absent, minimal, moderate, marked. Tachycardia, what causes that? Bradycardia, what causes that? How often do you monitor fetal heart rate? I showed you exactly where to look for that. Okay. How often do you monitor mom's vital signs? I showed you where to look for that in your book. Talked just now about precipitous delivery. Stay with your patient. Remember all that? 5 Ps, that's our passenger. That was talking about fetal attitude, lie, position, our contractions. Remember how to monitor contractions, how to measure contractions, internal versus external. After delivery, we talked about Pitocin, VBAC contraindications. Why did they have one the first time? What type of incision? I showed you what to look at for types of episiotomies, first to fourth. And then we talked about each one of these complications. How is a mom going to present? And what are our interventions for each one? Okay, we know the difference between external, internal. Internal is invasive, mom has to be ruptured. Internal IUPC can monitor the contraction strength. Spinal headaches, I skipped over that, but that is a potential complication of an epidural or spinal. So read about that. How do you fix a spinal headache? You would use an autologous blood patch. Basically, anesthesia does that. They draw blood and inject it right into that area. With a spinal headache, you kind of know if mom has one. When she lays flat, the headache goes away. When she sits up, it's like pounding. You can use other things like caffeine, oral analgesics, but really the best method to cure a spinal headache is an autologous blood patch, meaning they take blood from mom and inject it back into mom, and then that blood can kind of seal off that leak with a spinal headache. Okay, well, that was my review. If you have any questions, please let me know. Again, it's 40 questions, 40 minutes. You have the one math. And yeah, if you have any questions in the meantime, please reach out to me. I am going to go back to my screen here and get a drink because I've been talking for an hour. So happy studying. If you need anything, please let me know.